I am extremely personally privileged and honored to invite the next two speakers and to introduce them. Dr. Stacey Frisch is an attending physician and medical education fellow at Maimonides Medical Center in Brooklyn, where she is advancing resident education through the use of innovative curricula and development of a women's mentoring program. Previously, Dr. Frisch was a chief resident in emergency medicine here at SUNY Downstate and Kings County Hospital. She has a special interest in medical education and gender equity. The next is Dr. Melanie Cheng, a pediatric hospitalist and assistant chief academic officer for GME at Kings County Hospital Center. She graduated from SUNY Downstate Pediatric Residency Program, where she also completed 2 concurrent fellowships in general academic pediatrics and was the inaugural fellow for our SUNY Downstate GME Leadership Fellowship. She is passionate about improving diversity, equity, and inclusion in the clinical learning environment for all medical trainees. Her current efforts are focused on faculty development, mentorship, and advocacy. I'd like to say that both of these physicians are my mentees, and I have learned a great more from them than I think I've even provided them. And so it is a special honor to see them both speaking today. I'd also like to again acknowledge Dr. Melanie Cheng, who helped us to organize this event today, and the support from Kings County Hospital in providing her and her brilliant mind in gathering all the speakers today. Thank you both for joining us to share your talk titled "Guilt and Shame Are Not the Same, Building Psychological Safety into the Learning Environment."
Thank you so much for that wonderful introduction, Dr. Smith. We are very excited to be here, and thank you to the organizers for having us. We are just so excited to be here and sharing the stage with such wonderful speakers. This morning's session was absolutely fantastic. So kudos to all of the speakers from this morning. We are going to be talking about guilt and shame, creation of a psychologically safe learning environment. And I am excited to be giving this talk alongside Dr. Melanie Cheng as well.
Thank you. And again, also thank you for that wonderful introduction and the opportunity to be here. I think Stacey and I are both thrilled and hoping to keep up the high bar that has been set this morning. So we're going to start first just with our brief objectives. So the goal of this talk is to describe the concept of psychological safety within the learning environment, to compare guilt and shame, to interpret how guilt and shame may affect learners and how they relate to psychological safety in the learning environment, and to discuss strategies on how to use strategies such as setting clear expectations, modeling effective feedback, leading by example, and normalizing failure to improve the psychological safety within the learning environment. All of these objectives could be their own workshop, and we know that our audience may be at varying stages of exposure to them, so we're going to give a broad overview of these, and we will include some resources at the end for further reading. So the first question I just wanted to ask everyone, and you can use the chat if you would like, what does a successful education culture look like? So what are the most important attributes that you define in a successful learner, or your version of success within a learner? I want to open with an example that I view as a success, although traditionally may not have been viewed as one. While I was covering the nursery, I was the attending on with an intern who called me with a critical value. This resident had a strong fund of knowledge and had previously shown a consistent pattern of calling me with a well thought out research and evidence-based plan. This instance, she called me with urgency about a baby whose hemoglobin was around 24 and the hematocrit was around 60. It was clear she had seen this abnormal value, recognized that it may be a risk to patient safety, and called immediately. When I calmly asked her, "Okay, what would you like to do?" She took a breath and said, "Oh, okay, can I get back to you?" I said, "Of course." Within 5 minutes, she replied that she wanted to repeat a central sample to confirm. When I arrived to the unit shortly after, I told her that what she did was really important and that it grew my trust in her abilities, to which she seemed very surprised. I explained to her that in the context of already knowing that she always came with a prepared and thought out plan, what this showed me was that she knows when to ask for help. She knows her limits, and if she has even the slightest concern that a patient's safety is at risk, she will call for help even if it requires interpersonal risk. As attendings, one of the most important aspects of our relationships with our learner is trust. The scariest situation is supervising a learner who cannot or will not recognize their own limitations or risks to patient safety. Trust does not mean our learners have all the answers, but it does mean they will speak up, know their limits, and know when to ask for help.
We're going to define and talk about what is psychological safety. And then we're going to go over the differences between shame and guilt, what their effects are for our learners, and the consequences of an environment that induces shame. We'll talk about the shame spiral and how shame is experienced in terms of affective, cognitive, and action tendencies associated with shame, especially specific to medical culture. And then we'll talk about moving from a blame culture to a culture of safety where everyone feels comfortable expressing ideas. And we really want to make this talk tangible and actionable. And we will give some specific examples that we can use to, instead of using shame to motivate learning, place an emphasis on growth and on learning. So first, we can't really talk about shame without talking about the concept of psychological safety. Psychological safety is defined as the ability to behave or perform without fear of negative consequences to self-image, to social standing, or to career trajectory. And the establishment of psychological safety is essential to optimal learning. For individuals to feel psychologically safe, they must feel that they can express their concerns, they can ask a question, and they can acknowledge a mistake without fearing humiliation, retaliation, blame, or being ignored. We as people in general are motivated to naturally protect ourselves from ridicule, from embarrassment, and from shame. And in medical education, this manifests when learners are not offering ideas, when they're staying quiet, when they're not asking questions, or by withholding themselves from challenging the status quo. But really, we want them to be able to do these learner-oriented actions in order to improve their growth and their learning as trainees. Medical trainees in particular are motivated to protect themselves from shame because they're often being evaluated, they want to display independence, and they want to establish credibility. So when learners feel that they can be viewed positively, even when they make mistakes, even when they answer incorrectly, they will then participate in these learner-oriented behaviors, such as asking questions, sharing their thinking, and asking for help. And that's really the type of culture that we want to embody.
So there are a few key elements of psychological safety within the context of effective education and performance in the workplace based on the research that has been done to date. So the first is setting the stage. This means framing the work and the expectations of both the learner and the teacher. Clear teacher and learner expectations are crucial to a successful learning environment. For example, start a rotation on the first day by saying, I expect you to escalate if you are uncertain, to get things wrong. And if you don't, then I know you're not pushing yourself in this rotation. Set the expectations clearly that you expect them to voice their opinion, to ask questions, and to make mistakes. When you set the stage that way, it shows the learner what success will look like, and it doesn't mean avoiding failure. The second is to invite participation. This requires situational humility, modeling our own limitations, acknowledging that we may not always have the answers, recognizing that if our learners are not making mistakes, giving suggestions, or disagreeing, your team likely lacks psychological safety. The fear for learners shouldn't be, I am hearing bad news or wrong answers. The greatest fear should be that I am not hearing them. If your learners are not making mistakes in front of you, it doesn't mean they've mastered the knowledge. It is more likely that they are hiding or covering it up, that they're making mistakes that aren't being discussed, or that you are not able to uncover their knowledge gaps. In psychologically unsafe spaces, shame does not lead to preventing mistakes, but it may lead to covering them up. And the third is to destigmatize failure. We need to make the conceptual difference between the different types of failure. Leaders who respond to all failures with the same reaction will not create a healthy learning environment. For example, in research, when failure occurs because someone violated a rule or a value, this is not the same as when a thoughtful hypothesis turns out incorrect. A hypothesis with an unexpected finding is a good thing. It welcomes new knowledge, and welcoming these failures can foster learning. New data is good news, whether scientific data or addressing where gaps in knowledge are. If we are never, quote unquote, failing, we are no longer learning. Being wrong does not equate being a failure, but never failing will limit us from achieving our highest potential. Now, there are many barriers to psychological safety, both within the individual team structures, organizational cultures, and the medical culture in general. Some of these include, but are not limited to, the role and influence of the hierarchies and power differentials, the negative and often counterproductive intolerance for failure, and what we will be focusing on today, the misuse of shame as a motivator. Historically, medical education culture has viewed shame and guilt as motivators of learning and resilience. And shaming experiences can lead to debilitating emotional and physical reactions, including social isolation, disengagement from learning, loss of empathy, unprofessionalism, and impaired learning. Shaming and humiliation are not recommended as ways to incentivize learners. These negative aspects of the hidden curriculum essentially teach students and residents to avoid and suppress emotion, to be defensive, to appear apathetic to patient concerns, and they stifle curiosity and focus on protecting the ego at the expense of learning and growth. Medical students, as we discussed earlier, present numerous challenges that may provoke a shame response in the context of medical education, and these include challenging team dynamics, exposure of knowledge deficits, unexpected failures, and frequent transition periods. Furthermore, environmental influences such as suboptimal learning environments, mistreatment from others, lack of vulnerability demonstrated by our superiors, intense competition, and hierarchical pressures may contribute to shame or impede our learners' ability to reach out for help if it does occur. Given this destructive potential for shame and its links to the negative outcomes in medical learners, educational innovations are needed to enable medical students and residents to proactively and constructively engage with this emotion.
We want to make sure that everybody is understanding the difference between shame and guilt. Shame is a negative emotion that occurs after a triggering event in which the person feels a sense that they are globally flawed or deficient without distinguishing the behavior from themselves. So for example, there was a case in the ICU where there was a resident who was preparing and actually had gone through with a discharge for a patient who still had a PICC line. The resident realized before the patient left that the patient still had a PICC line, even though all of the discharge planning had already happened. And when the resident presented this to the attending said, "How could you not know about this? How could you let this happen? How could you be the one who made this mistake? Where did you even go to medical school? You aren't a trusted senior resident. You can't be trusted," etc. And in turn, the trainee felt like they were a failure, not competent to be a doctor, and that they were stupid. But in reality, many things probably contributed to this event. And if we look at it from actually a systems view, how did we let this happen? This is not just the fault of the resident, but rather we might be able to identify certain systems issues that could be addressed. But instead, with this type of response, the resident is feeling shame. They're feeling that they themselves are a failure, and this is unlikely to lead to productive learning and more likely to foster anxiety and avoidance, and in the future, potentially covering up mistakes that could be both dangerous for patients and not productive to learning. In contrast, guilt occurs when something triggering like a behavior or a circumstance is attributed to that behavior or circumstance rather than to the person themselves. So this is the idea that a learner will say, "I did something bad," rather than "I am bad." And guilt can actually be a constructive emotion that can stimulate personal growth. If we aren't feeling guilt, we're probably not human. Everybody has guilt at times, and this is just the consequence of failing. We want our learners to be able to feel this. And, in this instance where you have a patient who might have almost accidentally been discharged with a PICC line and the resident had brought this to the attending, a better response might be, "Thank you so much for bringing this to my attention. What do you think is the best solution at this time? And how in the future can we prevent these types of issues that contributed to this?" In this situation, the resident might still feel guilty, and that's a healthy reaction, but we can normalize this guilt to foster productive growth. So that transitions this experience from one where the resident is led down a shame spiral and a pathway of feeling bad about themselves to really an opportunity for growth and change. And when we empower learners to affect change, we can allow them to involve themselves in ways that they can think about how they can improve for the future. Does anybody recognize this speaker, author, incredible human? This is Brené Brown, and she is a shame researcher. She writes that shame is a focus on self and guilt is a focus on behavior. Shame is the idea that I am bad, whereas guilt is I did something bad. And shame is correlated with addiction, depression, violence, aggression, bullying, suicide, and eating disorders. And in the learning environment, it's associated with social isolation, with disengagement from learning, loss of empathy, unprofessionalism, and impaired learning. Whereas guilt is inversely correlated.
Yeah, I don't have access to have those procedures. It only takes a long time.
Guilt is inversely correlated with these things. It's uncomfortable, but it can be adaptive, and guilt can be leveraged to foster curiosity, growth, and mastery. According to Brené Brown, the first things that you need to know about shame are that it is universal. It's one of the most primitive human emotions. People who lack shame are basically sociopaths. And she says that you either fess up to the fact that you have shame or you admit that you're a sociopath. So shame is an expected and somewhat normal human emotion. And we're afraid to talk about it, but the more that we are afraid to talk about shame, the more control that it has over our lives. Shame needs silency and secrecy and judgment to grow. So the two most powerful words in combating shame are me too, and just normalizing this experience. When a medical trainee experiences shame, what does that look like for them? This could be the result of a shame trigger that includes being humiliated in a group session, being questioned with the intent to humiliate, maybe answering a question wrong in an unsafe environment, being interrupted, feeling judged by their peers. There's a shame researcher in medicine named Bynum, and they write a study of 12 medical students where they describe different experiences of shame in their medical training. The medical trainee said, I feel like I am swimming in my own body and like the wind was taken out of you. These are the words that they use to describe a shame reaction and how it felt to them. One of them said that they just want to go home. I don't want to see anybody. I want to go to bed. And many describe this feeling of wanting to escape. And these shame reactions are sentinel emotional events for many. And these are jarring experiences that can have significant physical and psychological effects. But whatever the trigger, the participants described a surge of affective emotion that was a fight or flight response, acute anxiety and fear, a desire to run away, a desire to hide. This physical feeling has been described as turning red and trying not to burst into tears. And it often leads trainees to experience these emotions in private, whether from a bathroom stall in an office. This is the feeling that you want to escape. And while you're in private, I'm sure everybody can relate to a time when this happened to them and they experience these fight or flight symptoms. You move to an episode of privacy and you start having all of these thoughts ruminating. And this is the spiral of the shame reaction. This is when people start having feelings that spiral out of control, depicted by these incredible illustrations where the learner starts thinking, what's wrong with me? Am I stupid? Am I lazy? Am I incompetent? And this sort of spirals further with all of this negative talk about the self, where an individual feels so discordant from how their actual reality is that they don't see that their positive aspects of themselves can outweigh the negativity that's going on. And this is the idea of the shame spiral. And this really needs, this really needs to, it needs many things in order to improve. After this deep episode of, a private negative feeling about yourself, hopefully there's a last stage, which is restabilization. And there's numerous factors that can positively influence this process. This might be opening up to another person and you see the other person offering help in this instance to try to unskew the frame of reference, to normalize the shame, to say, this has happened to me too. This can be normal. This is a normal part of learning. And, this also might involve some aspects of the learner themselves, practicing self-compassion, focusing on actions that can actually be improved and orienting towards growth-specific strategies that can help with this experience for both this episode and in the future. I like this arrangement of dominoes to represent an individual's identity as a whole. And you can see that each domino represents an aspect of that identity. For many learners, the dominoes rest on unsteady grounds because aspects of their identities and aspects of themselves as a whole risk falling. And this fragility is especially salient during transition periods. So during the introduction to clerkships, during the start of residency or intern year, during the start of a new rotation, these could potentially be times when a learner feels psychologically unsafe and learners might feel like they don't belong. So in this incredibly fragile environment, in the presence of a shame trigger like mistreatment, one of the dominoes can fall, and you can see how easily subsequent dominoes may fall, setting into motion a cascade that threatens the individual's sense of self. One of the things that we hear about, when we started to talk to our colleagues about shame in medical education, one of the responses that we heard is this just the idea that we're now training the snowflake generation who's so sensitive and we're so afraid that we're going to be hurtful to them that we can't actually give corrective feedback and we can't hold them accountable. And that's absolutely not what we're saying. I really like this diagram because it shows that psychological safety and accountability for performance down here are actually on totally separate axes. You see over here is the comfort zone. This is what they're describing. They're describing a time when Maybe the learners feel psychologically safe, but they're not being held accountable for their performance and they're not really pushed to improve. This is not what we're talking about here. And then on the opposite end of the spectrum over here, we have the anxiety zone. This is where we're holding learners really accountable for their performance, but in a psychologically unsafe way. And in this type of environment, learners are not really going to be able to capitalize on growth and learning because they're so afraid to speak their mind, to take risks. But what we're really aiming for is in the upper right corner here, the learning zone. This is where we are still holding learners accountable for their performance. We expect that they'll be learning and improving themselves, but we're doing it in a manner in which they feel psychologically safe to make mistakes. We're not necessarily saying that you can't give feedback or corrections. We actually want learners to be receiving feedback that's actionable and that can help them. We are just asking that feedback and corrections be given with a high degree of psychological safety and with this in mind, because when we're so worried about, about like losing the opportunity to correct our learners, this is not really what we're talking about. We're not talking about losing accountability for performance just because we're worried about hurting the learner's feelings. We're really talking about giving this feedback in a way that remains psychologically safe. And how do we do that? So one of the areas of staying in the learning zone that's key to that's key to this is the idea that as the learning area becomes more psychologically safe, there's more of an emphasis on growth and skills. You can see here that when there's a heavy emphasis on evaluation and grading, it can contribute to fear of failure and students wanting to protect themselves from being viewed as weak. And this can often result in knowledge gaps being obscured because students are afraid to speak up, afraid to take risks, afraid to ask questions, or afraid that they will be incorrect. But when psychological safety is high, the emphasis can be on growth and skills, and students can ask questions. They can feel that they're actually responsible for their learning and for self-evaluation of their knowledge gaps and their performance weaknesses.
So how do we improve? Psychological safety is shaped by leadership. And educators are leaders. They're leaders in the role of our teams, in our wards, within the departments. Leaders can promote psychological safety by inviting participation and responding supportively. Setting the stage involves framing and emphasizing the purpose of the work and creating shared expectations and meaning. Behaviors such as direction setting, inviting input to clarify, improving the work environment, creating conditions for continued learning, are not unique to so-called strong leaders, and they are available to everyone. And in this matter, the medical team may restructure their self-identity as a learning laboratory rather than a teaching institution or a teaching team. So there's been a recent recognition of the idea of the culture of safety when it comes to patient safety. And we have to realize that psychological safety for all of the people involved in the clinical arena, including med students and residents, it is critical to building that safe environment for patients. So if we care about the culture of safety when it comes to patient safety, we have to put an emphasis on creating psychological safety. Learning from failure does seem to rely on participants' ability to rebound from an error without becoming paralyzed by fear or shame. And that's the area that we really need to work on. So I want to circle back to the initial question that I asked in the opening. What does successful education culture look like to you? So out of some of these values, what are some of the things that you look at as success when you have a learner that you helped shape or that you had any part in teaching? Are they someone that you trust? Is it that they have a strong thought process? Is it that they can identify their own knowledge gaps? Is it that they always have the right answer? That they're independent? That they have good test scores? Is it that they can critically think, that they understand what failing safely means? Is it that they're curious and have the ability to speak up? Right now, we, and by we, I mean the medical community at large, prioritize scores, the right answers, and the avoidance of failure, rather than how to think, how to acknowledge our limits, how to speak up. And these are critical for patient safety. So just circling back to what the three major components of psychological safety are and how we can improve and try to limit shame within that environment or teach tools that combat shame. So the first is setting the stage. And this means setting your expectations from the beginning. Framing expectations regarding accountability, like we mentioned before, works in both ways. So demonstrate that you will hold them accountable by demanding that they hold you accountable. For example, you can start the rotation by disclaiming that we set high standards because we want to do the best for our patients. So we're going to set high standards by holding people accountable when you don't meet those standards. So let's start with me. Here are the standards we are going to set, and you will ensure that I'm held accountable to those standards. And when I fail to meet them, the expectation is that you will tell me about my shortfalls, you will tell me what they look like, and we will learn together and we will move forward. So setting the expectation of what defines strength in your rotation is another way to set the stage. Historically, vulnerability, failure, not knowing answers, asking dumb questions were all characterized as weakness. But courage, being right, confidence, these were considered strengths. But we really can't have courage without vulnerability. You cannot gain mastery without curiosity. So we must reframe what strengths look like by asking questions, speaking up, being curious, having a growth mindset. And then we must follow through with this expectation. Our evaluations and our feedback must reflect this, and our day-to-day interactions with our residents and our learners on, whether it's in the clinic, in the classroom, or on the floors, have to also reflect this. We have to learn how to respond first with rewarding curiosity and questions, regardless of what those answers may be, as we work to change this culture. And that doesn't mean we don't correct their wrong answers. It means that first we acknowledge it was hard for you to speak up. It was an interpersonal risk for you to do that. And that's a good thing that you did. And now let's work on growth. The next is inviting participation. So set a precedent for speaking up. For example, Navy SEAL Admiral William McRaven is one of America's most decorated military leaders. He led the missions that captured Saddam Hussein and killed Osama bin Laden. And he went to great lengths to build psychological safety within his teams. He made it clear that he wanted to be corrected and challenged. And one way he set the tone for speaking up was to say something completely outlandish to his team at the beginning. And if no one spoke up, he would confront them by saying, okay, I just said something completely idiotic. Who here has the courage to tell me I'm an idiot? This is ridiculous. You all fail. Then he would explain that he did this early on to create an environment where speaking up was the expectation. He wanted to cultivate an environment where his team was fearless in telling him that something was wrong because the stakes were too high. The military, similar to medicine, has very high stakes and has been built on a foundation of hierarchy. However, here we can see that breaking down that hierarchy to create psychological safety can lead to great success. Reward feedback and participation. Again, even if the answers or suggestions aren't always right, lead by thanking them for voicing their concern and acknowledging how hard it was to speak up. Eventually, as our culture shifts, we may not have to have quite the same emphasis on that. But right now, we definitely still need to lead by acknowledging how hard that was because we're not there yet. Secondly, you have to recognize your limitations, both as an educator and as one person in a larger educational system. So I think Dr. Jose had asked a question about this earlier. Sometimes just the title alone shifts the power in the hierarchy. And it may not matter how much you say that you want them to ask questions or that you want them to acknowledge your failures. There still will be an element because of the way our whole system is set up that invites some sort of threat. Creating psychological safety can't be done in a vacuum. It can't just be one attending or one rotation that provides psychological safety. It takes time and consistency, which we don't often have with any single group of learners. So we need to recognize that our learners are coming to us from all levels of experience, from different styles of training, many with shame as a predominant motivator. While setting the expectation that speaking up is rewarded, we have to also provide other avenues that invite participation. So on this slide, we've provided some examples of ways to invite participation, and we will provide links to these resources at the end of our talk. But for the sake of time, I'm only going to discuss one of these strategies. So I want to touch briefly on the use of resident-led rounds or independent rounds as a useful tool that's been adopted by many institutions. And the data has shown that it has contributed positively to all trainees' development. It increased senior residents' motivation to take full ownership of their patients and the educational needs of the team. All trainees reported unique learning experiences in the absence of the attendings, and it gave a safer space for medical students and third and fourth year medical students and junior residents to ask questions that they may not have asked otherwise. I have personally recently adopted this as part of our inpatient rotation, and the feedback has been positive and consistent with these findings. Many of our med students and residents have voiced that there are simply questions they won't ask when the attending is there. And sometimes that's just simply because they don't want to waste the attending's time, even when they're encouraged to ask. So it's really important that we do offer other avenues for them to speak up, bring their concerns, and ask those questions in a way that feels safe for them. So leading by example is another very effective way, and arguably one of the most difficult ways that we can increase psychological safety. Spend time doing the work of your learners. It can be a great way to break down the power differential and demonstrate reciprocal learning. There is a lot about the day and the workflow that we would have to rely on our learners to teach us if we just spent a little time in their role. This situational humility can be an icebreaker to model vulnerability or quote unquote failure and resilience. Admit what we don't know, point out our limitations, and gain trust in our learners because they see us willing to do what we are asking them to do, and because they know we've thought it through. I'm sure many of us would have to rely on an intern for putting in specific orders or aspects of the workflow that wouldn't feel great and would show some vulnerability in having to ask if we just took the time. The notion that a leader is in charge and must know it all is incorrect, dated, and a barrier to growth. And in medical education, the culture in which being right, having all the answers, is a breeding ground for shame. It is what feeds the inner voices that tell us real doctors don't struggle, real doctors don't make mistakes, real doctors have all the answers. Many who have made it to this point are experts in performing and perfectionism and have intertwined their sense of identity and work and worth with their accomplishments in medicine. And this false notion that doctors know it all and don't struggle contributes to isolation, anxiety, burnout, depression, and even suicide. We must model vulnerability if we want to create a shame-resilient culture. Show when we don't know by modeling how to ask for help. Talk about our own struggles to demonstrate how to problem solve when we don't know the answers. Even small action steps can go a long way. As Dr. Mason mentioned earlier, acknowledging and apologizing for our missteps. If we mispronounce a name, if we overlook a learner's input, circling back, apologizing openly is a great way that we can model how to make mistakes. We can also lead by example by demonstrating openly that we don't have all the answers and that we don't know it all. For example, if you have a difficult case, be transparent that you don't know everything and use it as a teaching tool for how to teach critical thinking and the use of resources to solve a clinically complex dilemma. I'll give you a really quick example. Very recently, I had a patient admitted overnight whose presentation was uncommon, and my resident team didn't feel as comfortable leading rounds on this particular case. I made sure to show them that I also didn't completely know what was going on and shared with them that the first thing I had done was to phone a friend. I had already used our department brain trust, as the PICU calls it, to enlist the help of the PICU, ID, NICU, and surgery to just run my thought processes and make sure I wasn't missing anything, and to discuss what the next steps might be. I shared with them that the steps to take when you don't even know who to call, how to use your resources, and the importance of knowing your limits and asking for help is just as important as knowing the clinical answers. And I think COVID was a great opportunity for all of us to see that we don't always know the answers, but what we do need to know is how we can critically think and how we can come to solutions with clinically complex issues. Not only were we able to proceed with a productive educational discussion in which all of the learners were eager to participate and offered up differentials and asked many questions, but I do hope that it also allowed us to break down the fallacy that we must know it all.
So circling back a little bit to talking about feedback and how we can hold learners accountable to the shared expectations that Dr. Cheng talked about setting when you're setting the stage. Effective feedback begins with developing the educational alliance. And this includes the idea, and this has to be an idea that the learner has, that you as the instructor have their best interest at heart, and that the purpose of your feedback is to help them improve. You can actually tell them this in plain language. I'm going to give you feedback. I would set the expectation very clearly at the beginning. I'm going to be giving you feedback. I'm going to be giving you feedback because I want you to improve and be the best position that you can be. And I assume that you're trying your best. And the focus of my feedback is really just to help you improve. The earlier talk that we had on language and its importance by Dr. Jacoby and Dr. Jacobson-Dickman was also, I think language is also very important when we're giving feedback. So the manner in which we deliver the feedback can really influence the emotional response in the learner in terms of both the language and the actual manner of giving the feedback. So when possible, the feedback should be timely and provided immediately after an action. It should be done in a private setting so as to not humiliate the learner in front of their peers or in front of the others. And it should be scheduled when possible, or at least you should ask, is now a good time for feedback? Can I give you some feedback now? It's also important to provide normative support. This is the idea of me too, and breaking down the idea that we are all perfect. You can say things like everyone makes mistakes and this is a normal part of learning, and try to avoid harsh reprimands or putting the idea inside the learner's head that this makes them a bad person or a bad physician. And then after the feedback is given, we need to help students reflect on their emotional responses that they experience as a result of our feedback. No matter how great we are at giving feedback, no matter how good they are at receiving feedback, this can still be an emotional time. And similar to what we discussed earlier, where a patient is not only defined by their illness, our learners are not only defined by their weaknesses and by their gaps. And so we should help them see that feedback is meant to improve their growth and really describe how they can use this to better themselves. I want to give an example. I recently was sitting in on a resident's 6-month review, and I was sitting in just to observe, and the reviewer was going over faculty comments with the resident. And one of the faculty comments that was read about this resident was weird, but in a cool way. And I thought to myself, what is the resident thinking about this feedback? Do they think that it's a positive thing? Do they think that it's a negative thing? Why do people think that they are weird, or why do people think that they are cool? What does that even mean? If they did think that it was a negative thing, it might decrease their self-confidence, which might make them start to question whether they have capability to manage situations in the future. It might lower their goals. It might increase their avoidance of other people, or make them just quiet down and basically stop talking so much at work. But if they think about this as a positive thing, even if they think that it's a good thing, they don't know how to capitalize on the behaviors that led to this conclusion. So we see this a lot in other terms as well. How many times have we seen on an evaluation a pleasure to work with, or maybe we wrote it ourselves? But really, we need to give specific actions or behaviors that the learner is doing in order for them to really understand what it is that we want them to keep doing, or what it is that we want them to not do as much. So I'm going to give you an example. Instead of saying friendly, which is really a personality attribute, try to give something that was actually an action that you witnessed, or a behavior in which the learner acted friendly. Why do you think that why did they come off as friendly to you? So these are just some examples here. Did they elicit the patient concerns? Did they sit down at the level of the patients? Did they not interrupt? It didn't seem rushed. They maintained good eye contact. They offered tissues when a patient was crying. By giving these concrete examples of actions, we can actually positively encourage our learners rather than focusing on themselves as an individual or their personality and things that they might not be able to change.
So I just want to talk briefly before we have some time for questions, hopefully, about normalizing quote unquote failure. So as Dr. Mason referred to earlier, we were not necessarily always taught to fess up or admit mistakes or to fail. However, this new culture means new permissions need to be on the table. And part of that is normalizing failure and shame. We must break down these walls of isolation that are obstructive to effective learning. And we need to reframe that failing safely is expected. Again, for example, I don't expect you to have all the answers, but I do expect you to escalate. Failing safety does not mean a failure in patient safety. Beyond normalizing failure, we must reframe that it is a critical component of growth mindset. Take getting papers published, for example. How many rejections does it take before a paper gets published? If we shifted our frame to welcome rejection as a path to success, what might that look like? If we aim to get 100 rejections in a year, would it mean we actually increase our submissions and potentially successes without risking our emotional and psychological well-being? Would more of us have outcomes similar to Dr. Lee's wonderful paper, which we discussed earlier, which took its 8-year journey and surfaced at a time we probably needed it most? In an interview with organizational psychologist Adam Grant, a comedy writer named Emily Weber discussed how trying to create opportunities the traditional way was not working. So she set a new goal in 2017 to get 100 professional rejections by the end of the year. She discusses how that in itself empowered her. Rejection was now a win-win. And she ended up with 107 rejections and 43 acceptances in 1 year. And furthermore, she submitted to the New Yorker and the New York Times, which she had previously been far too intimidated to submit to, and was accepted to both. The bottom line is we need to normalize and encourage safe failure for ourselves and our learners as an expected and necessary part of learning.
So in summary, we call on you, our colleagues, those who round with and educate our students, our residents, our fellows, to join us in our pledge to end using shame as a tool for learning, to monitor ourselves and our partners for unprofessionalism, and to learn about and employ our own strategies for staying in the learning zone. And these are strategies that we talked about, such as setting clear expectations, modeling effective feedback, leading by example. For example, like Dr. Cheng said, when you don't know something, being honest and open about it, and normalizing failure. And these are just the first steps in shifting the culture from a culture of blame to a culture of curiosity, growth, and mastery. And we included for you a lot more reading on some of these topics. If you're interested, you can go ahead and scan this top QR code. That's our references. Thank you so much.
Thank you. That was absolutely wonderful. Another virtual round of applause. Very, very proud of both of you. That was fantastic. So we have about a few minutes, so I think we can take one question. If anyone has a question, please put that in the chat. How, as colleagues, do we pull at the coattail of another colleague who might be, lateral to us in academic titles when we're noticing behavior that could improve?
I can share that I actually had this happen to me recently. And actually it was not a lateral colleague, but somebody with a title hierarchically above mine, who was more experienced and been at the institution for longer. And what I said was, I wouldn't be staying true to my values if I didn't offer to give you feedback in this instance. Do you mind if I give you some feedback? And, we went aside to a private area and I basically said, this is what I saw and this is what it made me think of. And, maybe in the future, these are some examples of ways that I would do this differently. And then I just allowed some reflection. And actually after this, because this was something that happened in a group of people that other people had witnessed, I don't want to say the specific example just because, some people might be on the call, but because this was something that happened in a group of other people that other people had witnessed, I just demonstrated, that this is how I handled the situation around the learners who had witnessed this. And so I think just being really humble, making this something that's done in private so that it's not something that is going to be shame inducing, and just being really open and honest with, this is what I saw. You need to say an I statement. So this is what I saw. Maybe ask, what were you thinking in that moment? Have some inquiry, be curious. Maybe you just don't understand the intentions and it didn't come off that way. I would always assume the best intentions for everybody. Don't make assumptions that their intentions were meant to hurt. But just frame from how you saw it and how it made you feel, how it might've made somebody else feel.
Great. Well, thank you again. That was a wonderful talk. And I hope everyone was able to scan the QR code to be able to download the references. Thank you again. I think that was extremely insightful. Another virtual round of applause.
Thank you all for giving us this opportunity to be on this forum with such amazing speakers as well, and for the mentorship of both of you, I think, to both of us.
Thank you. Thank you very much.